Okay, thank you for having me. I'm Tomonari Takahashi from the Institute of Science Tokyo. Today I'm going to talk about paravascular abnormalities in myopic traction maculopathy. So myopic traction maculopathy, MTM, is a schisis-like thickening of the retina in eyes with high myopia. MTM includes lamellar or full-thickness macular hole and foveal retinal detachment. It is estimated to affect 9 to 34% of highly myopic eyes with posterior staphyloma. Pars plana vitrectomy is useful for resolving it. OCT is essential to diagnose MTM. The key factor of MTM is tractional forces. So what is the tractional forces? There are some reports about it. These 5, vitreomacular traction, vitreous cortex, retinal vessels, internal limiting membrane, posterior staphyloma, are considered to be tractional forces. Multifactor of these could make the MTM condition. Next, I'm going to talk about internal limiting membrane. So internal limiting membrane, ILM, is considered to be a main cause of traction. ILM is the basement membrane at the vitreoretinal interface, and it is consisted of type 4 collagen, laminin, and fibronectin. ILM is thicker in the fovea than in optic disc and peripheral area. The rigidity increases with age. So how can we decrease the tractional forces? Vitrectomy with ILM peel has been shown to result in anatomic resolution of MTM and to improve visual acuity. However, there is a big complication, postoperative macular hole. In 2012, Dr. Ho and Dr. Shimada invented fovea-sparing ILM peeling. Recently, FCIP technique is widely used for the MTM surgery. So today, I especially focus on retinal vessels. As for examination, we use retromode imaging. Retromode scanning laser ophthalmoscopy imaging uses an infrared scanning laser ophthalmoscope to capture a pseudo three-dimensional image of ocular fundus. Past studies revealed that there are 2 findings using retromode imaging, striae and fingerprint. Striae is like this picture. Striae is the linear lines that run radially from the macula. This is fingerprint. Fingerprints are consisting of dots and striae that have no fixed direction. This is the new findings, dots. Dots are granular findings near the macula. This is paravascular striae. There are straight lines that cross the retinal vessels like fishbone. We have searched total 56 eyes of MTM, 28 eyes, that half of the participants had paravascular striae. There were no significant difference between the retinal schisis type and retromode image findings. The retromode findings does not simply show the schisis structure. However, retromode findings, especially the difference of macular striae and dots are near the macula, could be the great implication for surgical intervention. The difference of 2 could be occurred due to the Henle fibers running. Dream OCT is the product of Intellite and the latest OCT machine. It is swept source OCT and the depth is 12 millimeter. We could get clear image of retina and vitreous. In this case, vitreous humor is tightly attached with a retinal vessel. There is no retinal schisis, but tight vitreous adhesion could be the main reason of retinal schisis. This is very important case. At a glance, this is a quite normal MTM case, and we think that ILM traction is the main cause of this MTM. However, when we see in detail, there is a vitreous adhesion to the retinal vessel. Vitreous humor attached hard to the retinal vessel, and that could lead to paravascular abnormalities and retinal schisis. So next, I will focus on paravascular abnormalities, PVAs. Some types of abnormalities have been reported, like paravascular microfolds, paravascular cysts, and paravascular lamellar holes, as shown in this picture. Paravascular microfold is a projection of retinal vessels toward the vitreous cavity. Paravascular cyst is a spindle-shaped dark areas or fissure-like lesion adjacent to retinal vessels. And PVAs is the cause of foveal schisis. So there are some reports about paravascular abnormalities. PVAs are detected in 82.9% of highly myopic eyes. Patients with PVAs are older, more myopic, and longer axial lengths. Paravascular holes are detected in 26.3% of the highly myopic eyes. The incidence of palavascular ramular holes are from 14% to 31.4%. So what is the cause of PBAs? First, palavascular palavascular microholes occur with aging, frequently accompanied by the vitreoretinal adhesion at the retinal vessels. Second, palavascular cystoid space appears around the palavascular microfolds. Third, palavascular ramular holes develop as the inner wall of palavascular cyst is removed by the vitreoretinal folds, or palavascular retinoschisis occurs with continuous vitreoretinal adhesion. So when we do vitreoretinal surgeries, we should care PBAs. From here, I will show you some representative cases of PBAs. This case is 64 years male with 32.55 millimeter axial length. Using ultra-wide field OCT, we could detect vitreous adhesion to palavascular area. Vitreous humor attached both sides of the vessels like bleach. We could detect palavascular lamellar hole and microfolds. Vitreoretinal surgery was conducted with complete island peeling and no tamponade. Day 1 after the surgery, we could not detect any complications. At day 7 after the surgery, palavascular hole was occurred. We could not know when this complication happened because the image was not clear due to postoperative inflammation and desmofold. With retromold imaging, it is easy to detect palavascular hole. During the reoperation, there was no ILM around the hole. We enlarged the PBD using forceps and tamponade with C3 F8. In this case, weird vitreous adhesion is probably the main cause of postoperative palavascular hole. Second case is 66 years old female with 29.46 millimeter axial length. We could detect posterior staphyloma with normal color from this photo. We could not evaluate PBAs correctly because we did not take the wide field OCT preoperatively. There was outer retinoschisis and outer retinal defect region. We conducted vitreoretinal surgery with complete island peeling and non-tamponade. At day 3 after the surgery, we could detect tiny palavascular hole. 1 month after the surgery, retinal detachment occurred around the palavascular hole region. Using retromold imaging, palavascular hole and retinal detachment region is easy to detect. In the reoperation, there was no ILM around the hole. We enlarged the ILM peeling area and did tamponade with SF6. Third case is 66 years old female with 27.53 millimeter axial length. At the first presentation, this patient has huge retinal detachment region. This case is also easy to detect posterior staphyloma, and retinal detachment is easy to detect using retromold imaging. During the surgery, vitreous adhesion around the palavascular ramular hole was so hard, we used forceps for removing that and did tamponade with air. Contrary to previous 2 cases, third case was severe, but there was no complication. So when we face the postoperative retinal detachment due to palavascular abnormalities, what can we do? There are 4 choices: additional island peeling, a laser around the brakes, inverted island flap, and autologous island plantation. Retinal plaques in the posterior pole usually do not enlarge if island is peeled. However, high myopia cases, especially high myopia with posterior staphyloma, there can be tractional forces because of the distorted eye shape. So what should we do in the first surgery? My answer is fluid air exchange. Normally, MTM could be treated without tamponade if the traction is adequately removed by surgery. And also, some papers reported that as for visual improvement in a long-term vitrectomy without tamponade is better than with tamponade. The eyes with palavascular abnormalities also has other vitreous adhesive lesion. And when we do vitreoretinal surgery for MTM, there is no case without postoperative palavascular hole. This phenomenon is similar to Schrodinger's cat. Of course, for the cases with deep posterior staphyloma, fluid air exchange cannot be effective. However, decreasing the risk is very important thing. So this is conclusion. Retromold imaging is useful for evaluating palavascular holes. Using ultra-wide field OCT is necessary for grasping the details of the patient condition near the vascular region. Island peeling should cross the arcade vessels. Fluid air exchange is necessary for preventing retinal detachment progress. Thank you so much.
Thank you so much. This is really interesting talk. So, so in your understanding, in particular, these retinal schisis, just trying to learn from you, how many proportion of this schisis is secondary to traction, and how many secondary to, I mean, the porting feature, just like the, the retina scene.
So you mean, how many percentage of the retinal schisis is
because of traction?
Oh, so I'm sorry, I don't have
histological features.
Yes, I don't have the precise numbers, but there are yes, many factors are affected to the retinal schisis conditions, and most of the cases just only peeling of the ILM is the resolving the conditions. So it is very difficult to grasp the conditions clearly because the vitreous adhesion and the ILM traction, both of those are the causes the MTM condition. So I'm so sorry, I can't answer you the precise number, the percentage.
Thank you. Are there any other questions?
So thank you for the just like surgical meeting. But yeah, I'm sorry that that's a surgical question. So I think regular ERM surgery, we remove the ILM just before the arcade vessels. But I think we should remain the ILM very close to the vessels. So I do surgery for this kind of patient with ILM removal. I remain one distance or half distance of ILM from the vessels. So we need to change the maneuver.
Yes. Yes, thank you for the comment. So I think so too, but for the myopic traction maculopathy cases, we should peel the ILM across the retinal vessel for resolving the tractional forces. And in some cases, I just show you some dream OCT cases. Those cases, vitreous traction to the retinal vessel is very hard. For those cases, we don't do the aspire the vitreous humor and pulling out is very dangerous because that can cause the palavascular holes, postoperative palavascular holes. For those cases, we think that the island peeling is first we should do. That can peel the gentry, the vitreous, decrease the vitreous traction from the retinal vessels. This is my proposal.
Actually, my question was for Dr. Pavan, but we quickly switched to the second presentation, so I would now. So first thing I want to ask is, in the axial myopia progression cases, you are taking both the increase in the axial length and the refractive error as well together to label it as a progression, and then we start some treatment, or either of the two?
Very good question. To label them as axial myope, we will definitely need axial length to say that, let's say there's -4. Axial length cannot be 22 millimeters. So you approximately have an estimate of, okay, it could be 25.5. That's a first step. Now you started them on treatment. Now the main parameter would be the change in axial length, because axial length changes you will see first, and then only later you will see the changes in refraction. Now you don't have to wait to see the changes in the refractive error also. If let's say at times, because myopes tend to have better depth of focus, they will be having 0.5 change in the refractive error, but they don't accept. So there is no point for us to wait if there is already more than 0.15 millimeter. I'm talking about the Indian context.
All right. One more question I had about the age criteria. Like at our hospital, we are taking 5-6 years as the cutoff to either give the defocus glasses or to start LD. So this is the age limit that we should be following, or we can start
I
it
think
early?
based on multiple clinical trials as well, it start with 5+ years, and even at LVP we tend to do the same beyond 5. But again, there will be change in the plan on a case-to-case basis. Let's say there is axial myopia, and then child is only 4 years. I'm sure there is treatment given at that stage as well.
All right. So that would be a defocus glass, because
Again, to start with, you want to stick to the optical management.
yes.
Unless there is high astigmatism or maybe high myopia, when you don't have options in the optical.
Okay. All right. Thank you.